Good afternoon. I'm glad to be here today with you and share some information about significant and fascinating topic, diseases of lungs and bronchi. I please you to register yourself to fill the Google form. Its link you can find at the end of the lecture announcement on our site. So let's start. On this slide you could find a list of current diseases that we are going to talk during this lecture about. But first of all, we need to revise some knowledge about normal anatomy of the respiratory tract. So, it consists of trachea, bronchus, small bronchioles, and finally alveoli. Exactly, alveolus consists of capillary endothelium, so capillary lumen, yes, inside the wall of the alveoli. Next one, basement membrane, and these bluish interstitial cells. And finally, we have alveolar epithelium. This epithelium contains two types of pneumocytes or alveolocytes. Type first, so these cells are flattened and as you see plate-like, so they are 95% of cells. And second type of alveolocytes, so these cells are source of pulmonary surfactant. You see this pinkish like granules inside the cytoplasm. And the second function of the second type of alveolocyte is the possibility to fill the place instead of dead alveolocyte type 1. So when some alveolocytes of first type died due to any reason, so alveolocyte type 2 proliferates and fill this free place. So this is scheme, and right now look at the real photograph. So according to the scheme, you understand that the thickness of the wall of alveoli is due thin. So you see just two layers of cells. So alveolocyte from this alveolus, and the second one is alveolocyte from this alveolus. So that's why the wall is really thin. Grossly lungs are usually, so normal lungs are usually soft because of high level of air inside, so high level of airness, and as you see color like grayish pinkish, so this is normal gross and appearance and microscopical appearance. And right now let's discuss problems. We start with term atelectasis, or in some literature you could find the term collapse of the lung. So what is atelectasis exactly? We have two main parts or variants, so-called neonatal atelectasis. So this atelectasis refers to incomplete expansion of the lung. And the second type, so we encounter principally in adults only this type. So it refers to the collapse of previously inflated lung, producing areas of relatively airless pulmonary parenchyma. So, atelectasis, as you see on this slide, has three main subtypes. So, resorption, compression, and contraction. So, resorption atelectasis is the consequence of complete obstruction of an airway, which in time leads to resorption of the oxygen trapped in the dependent alveoli without impairment of blood flow through the affected alveolar walls. Classical example here is obstruction or blockage of the lumen of the bronchus by mucus after the operation, for example. Next type is compression. Compression atelectasis results whenever the pleural cavity is partly or completely filled by fluid exudate, tumor, blood, or even air. So, pneumothorax could lead to the atelectasis because of the air, accumulation of the air in the pleural cavity. Next one, hemothorax, so accumulation of blood. Next one, pleuritis, because of the inflammatory exudate in the cavity. Tumor, we could have here example as mesothelioma. And last one type is contraction. Contraction atelectasis occurs when local or generalized fibrotic changes in the lung or pleura prevent full expansion. So we have some like scars, you see, and these scars like bind the surface of the lung and can't let them to increase the size. Next one, acute respiratory distress syndrome. So this is diffuse damage of alveolar epithelium and capillaries resulting in progressive respiratory failure that is unresponsive to oxygen treatment. And right now we discuss why. Look here, causes. As you see, shock, sepsis, trauma, preceded pneumonia, for example. And right now, I please you, do not mislead acute respiratory distress syndrome with respiratory distress syndrome of infants, because the last one is caused by deficiency of surfactant. So, main link in pathogenesis of the ARDS is neutrophils. So, these neutrophils release a variety of factors such as leukotrienes, proteases, oxidants, even platelet activating factors. That's why they contribute to local tissue damage, accumulation of edema fluid inside the alveoli, and surfactant inactivation, and finally, or eventually, hyaline membrane formation. So, hyaline membrane formation. That's why when we give an oxygen to the patient still has lower level of saturation, because through this hyaline membrane oxygen can't go. So we have two main stages. This is an acute one, and also we have a stage of a healing stage or resorption stage. So in the second stage, type 2 epithelial cells undergo proliferation, as we have said, in attempt to regenerate the alveolar lining. So that damaged and died alveolocytes type 1. So instead of them, we need to make some new alveolocytes. So very interesting that complete resolution is unusual. So more commonly we have an organization of the fibrin exudate with resultant intra-alveolar fibrosis. So complete recovery is absolutely uncommon. Also, please look here. Marked thickening of the alveolar septa issues. So is caused by proliferation of interstitial cells and deposition of collagen. So we have here both problems with alveoli, so with epithelial line of the alveoli, and in the second stage some proliferation of the alveolar septa or alveolar wall. So next group is pneumonias. So here you see some classifications of pneumonia, but what you need to memorize for sure. First of all, this one classification. So we have bronchial pneumonia, we have lobar pneumonia, and we have interstitial pneumonia. So first two, this and this one, are absolutely acute process with some complications but without chronic form. Oppositely, interstitial pneumonia is chronic disease. Look here. So what areas are affected due to each type of pneumonias? We discuss this on the next slide one more time. Also, I please look at this classification. So community acquired or out hospital and hospital acquired. So the most common type of pneumonia is obviously this one, so community acquired. But hospital acquired is one of the most severe. Why? Because hospital acquired means that patient gets a pneumonia inside the hospital. So microorganisms in the hospital are have classically multi-resistance for many types of antibiotics. So that's why it's really difficult to treat this type of pneumonia. Move on. So let's look at lobar pneumonia and bronchopneumonia in more details. So lobar pneumonia is characterized by consolidation of an entire whole lobe. And here we could easily to see the difference between affected lobe and non-affected lobe. So consistency of affected lobe will be more dense because there is absence or really low level of the oxygen inside the alveoli. Move on. On this slide you could see the stages of the lobar pneumonia. So congestion, red hepatization, gray hepatization, and resolution. And also look at the X-ray photograph of the X-ray exam. So here we have absolute absence of air in this lobe, as you see. That's why it is so dark. Yes, it is so dark. So four stages. Congestion, we have just or mostly edema, some inflammatory cells, but there is a predominance of the edema. Next one, this one is red hepatization. We have erythrocytes, neutrophils inside the lumen of the alveoli. It's important. So bronchopneumonia and lobar pneumonia, so all changes happen inside the lumen of the alveoli. Move on. Gray hepatization. Gray hepatization means that we have a lot of neutrophils, but also fibrin fibers inside the lumen of the alveoli. And final stage, resolution. So instead of these fibrin fibers, or on the base of these fibrin fibers, connective tissue forms. And one of the complications of the lobar pneumonia is so-called carnification, when we have too much connective tissue in the lung. So these fibrin fibers should be undergone with resorption by proteolytic enzymes of neutrophils. But in some cases, amount of these enzymes is not enough. So in the end, we have too much connective tissue and can name this as carnification. Obviously, as you see, this part of lung does not work, not like properly, but absolutely. So in this case, we can think about the chronic insufficiency of the lung. Next one. Compare with lobar pneumonia. Please look at the bronchopneumonia. Here we have patchy consolidation of the tissue of the lung. So you see multiple foci with changes. Look here. So patchy areas of tan yellow consolidation. Dark red color we have because of the congestion of the lung, because of the inflammation. Remember, yes, that we have increased amount of the blood due to the inflammation. Move on. Bronchopneumonia. Microscopically, so we have domination of the neutrophils. So here we have a lot of, and this part of the lung is absolutely or more aerated compared with this one. Here also we have in the lumen of the alveoli inflammatory infiltration, and in some lumen there is no inflammatory infiltration at all, or just a few cells. But please note that the structure of alveoli is saved. So that's why it is possible to recover. And then these alveoli will work. Here you could see high magnification of the bronchopneumonia, and you see here again domination of the neutrophils, some erythrocytes, and you see here hyperemia. Hyperemia, you see, so dilated capillaries because of the inflammation. So this is the pathological type of the hyperemia, inflammatory hyperemia. But there is no fibrin fibers. You see, there is no pinkish lines inside the lumen of the alveoli compared with lobar pneumonia. So, destructive complications of the pneumonia. First of all, this is an abscess formation. So this abscess is an acute one because we do not see the wall of the capsule. So the main difference between any chronic process and any acute process is presence of connective tissue. When we are talking about cavity, so place of connective tissue is the boundaries of this cavity. So if there is a capsule, it should be something chronic. So if here we do not see any whitish thick wall at the periphery of the cavity, so this is an acute abscess. Moreover, look please on the X-ray graph. So here we have a horizontal level, you see? Horizontal level means fluid, and classically horizontal level relates with some binding with environment. Move on. Next list of complications contains pleuritis, two types. You see fibrinose and purulent pleuritis. So fibrinous pleuritis, when we have some membranes on the surface of the leaf of the pleural cavity, and purulent pleuritis with accumulation of some firstly neutrophils. And when we have exactly pus and a lot of pus in the pleural cavity, we can name this situation as empyema of the pleura. Empyema of the pleura. Move on. Specific term is atypical pneumonia. Very interesting and I can say rare situation, but you need to recognize it as well. So this term used for interstitial pneumonitis without consolidation. So there are no classical feature of pneumonia. That's why pneumonitis. And interstitium is mostly affected compared with bronchopneumonia or lobopneumonia. Classical causes here is mycoplasma pneumonia and influenza, but not only. So viral pneumonia classically is characterized by domination of lymphocytes macrophages, so mononuclear infiltration. Despite the fact this pneumonia is acute process. Next, two examples of viral pneumonia with specific features that you could use during your MCQ test CROC 1. So, respiratory syncytial virus has gross multinucleated giant cell. You see here, 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 here as well. Cytomegalovirus pneumonia is characterized by intranuclear inclusions surrounded by a small clear hollow. Classically, this type pneumonia is or associates with immunodeficiency syndromes, for example, HIV infection. But immunodeficiency syndromes include a lot of diseases, not only HIV infection. Next part is about chronic problems of lungs. There are two main groups: obstructive diseases and restrictive diseases. Obstructive diseases means, according to the name, obstruction of the lumen of the bronchium. In this case, patient can't breathe out. Classical example is bronchial asthma, and I know that you talk a lot about this disease on mostly each department in our academy, so there is no new information that patients with this disease have a specific pause, orthopnoea. During this pause, they involve all muscles of the chest and neck in breathing. So, obstructive disease. So, patient can't breathe out. It is difficult to do this. Restrictive disease. Restrictive disease means increased the thickness of wall or septa of the alveoli. So lung does not work, because of this, lung does not work properly. And patient could breathe in, could breathe out, but it providing the breathing, patient can't breathe enough. That's why usually these patients have increased heart rate, increased breath rate, but still the level of the oxygen is not enough. Classical check of changes in the lung, and you will do this check for your patient. So this is spirometry, and this exam shows us what patient can do and what patient can't do. According to the results of this exam, we could make a decision. So what disease is this? So why do you need this information? Because when we know exact name of disease, for example, bronchial asthma or anthracosis, obviously we understand that this disease is obstructive or restrictive. But when you are in the diagnostic process, so exactly inside during it, so you are diagnosing right now and try to name the disease of your patient, you need to understand, so what is the capacity of the lung? What patient can't do, breathe in or breathe out. So this is the list of the most common obstructive diseases of the lung. So we have chronic bronchitis, we have bronchiectasis, asthma, emphysema, and bronchiolitis. So let's talk about them. So chronic bronchitis could lead to the emphysema. Chronic bronchitis is caused by, classically, especially in your MCQ, by smoking. So this is classical MCQ, so patient smokes and logically has a chronic bronchitis. Then, due to the obstruction and presence of air, permanent presence of air in the lung, additional air in the alveoli. So this air with time, so amount of this air with time becomes bigger, press on the alveoli septas, and these alveoli septa become thinner and thinner and thinner, and one day they rupture. So this ruptured walls of the alveoli and really thin wall of the alveoli has a name of emphysema. So here you see the classification of major types: central athenar, pan-athenar, distal athenar, and so-called irregular emphysema. But I also want to give you another important classification of the emphysema. There are 4 main types, so I please you make some notes. So first of all, this is compensatory hyperinflation or emphysema. So the term is sometimes used to designate dilation of alveoli, but not destruction of septal walls in response to loss of lung substance elsewhere. Second type is obstructive overinflation. Obstructive overinflation, classical cause is chronic obstructive bronchitis. So, obstructive overinflation refers to the condition in which the lung expands because air is trapped within it. Next one is bullous emphysema. So, this type of emphysema refers merely to any form of emphysema that produces large subpleural blebs or bullae. So what is bullae? Bullae, this is a spaces more than 1 centimeter in diameter in the distended state. The next important point: rupture of the bullae may give rise to pneumothorax. So, classically, when patient had a trauma or someone hit the patient in the chest, or patient just had a cough, so in this case, bullae can rupture, and this is a closed pneumothorax. A really severe complication of the emphysema. Patient can die. So, on this slide, you could see some differences between central athenar and pan-athenar emphysemas. So, as you see, the most common type is central athenar emphysemas. Move on. On this gross spacement, you could see this bullae. So, as you see, numerous large bullae. And again, so rupture of this bullae could lead to the pneumothorax. So, please look at this sentence. Also, there tends to be some scarring with time because of superimposed infection. So, we have some stayed air inside the lung. So, that's why some microorganisms are permanent in these alveoli. So, they live there, they won't leave and actually can't leave these alveoli. That's why it could lead to the infection. But what's the most interesting part? The emphysematous process is one of loss of lung parenchyma, not fibrosis. So, we said, and actually we repeat this many times, that classical outcomes of mostly each process is connective tissue formation, so sclerosis or fibrosis. And all diseases of lungs, so like pneumonias, bronchopneumonias, lobopneumonias, or interstitial pneumonias, or chronic diseases of lung, all of them lead to the pneumofibrosis. And due to this pneumofibrosis, we have chronic respiratory insufficiency. Emphysema is an opposite state. We have problems with the lung, yes. We have respiratory insufficiency, yes. But the cause is not a connective tissue spreading. The cause is thickening of the septa of the wall and eventually rupture of them. So gross specimens, you see centrilobular, panacenar, distal, and microphotograph. Classical microphotograph, when you see increased thickness of the wall of the alveoli and some foci of rupture of the alveoli. So emphysema is characterized by a loss of lung parenchyma by destruction of alveoli, so that there is permanent dilation of air spaces. Chronic bronchitis. So chronic bronchitis could result in obstructive emphysema. So features of chronic bronchitis. Let's see. First of all, word chronic means presence of connective tissue, presence of mononuclear infiltration, so monocytes, lymphocytes, plasma cells, macrophages, etc. Next one, we have also hyperplasia of the glands. Look here, so there are just few glands, yes, and when we have chronic inflammation, there are many glands. So hyperplasia, increased amount of cells, yes, hyperplasia. So hyperplasia of glands, that's why we have increased amount of mucus in the lumen. So this lumen, this mucus also leads to the narrowing of the bronchilumens. Next one, please look here. So classically, bronchi are lined by one layer, you see, one layer epithelium. And due to the chronic inflammation, we have hyperplasia of this epithelium. You see, so 1, 2, 3, probably 4 layers of epithelium, so hyperplasia. And with time, this hyperplasia becomes metaplasia. So instead of glandular epithelium, we have squamous stratified epithelium. So metaplasia due to the chronic irritation. So hyperplasia becomes metaplasia, and this metaplasia could become dysplasia, and then the next step will be for sure squamous cell carcinoma of the lung. So that's why chronic bronchitis results in emphysema, obstructive emphysema. Chronic bronchitis results in squamous cell carcinoma of the lung as well. Next one disease is bronchial asthma. So again, we are talking a lot on each department about this disease. I remind you that this is a main problem with immune system. This is hypersensitivity reaction type 1, and I also emphasize on main classification of the bronchial asthma. We have classical, the most common, atopic asthma, when we have exact allergen that stimulates the cough, the spasm of the bronchi. Non-atopic asthma is treated by a process including respiratory infections, usually viruses. Drug-induced, I think it's clear, and occupational asthma is caused by workplace triggers, classically dusts or fumes. So atopic, non-atopic, drug-induced, and occupational. So what happens? So this is normal bronchial tube, and this is, so you see, so narrow. Why? So there are four main components of narrowing of the bronchial tube. So first of all, this is, as you see, mucus. You see, mucus. So hypersecretion of the mucus. Next one is increased the thickness of the mucous layer of the wall. Next one, the third one, is spasm. So that's why when patients take the specific pills, we have, we relieve the breathing because we eliminate the spasm. And the final component of narrowing of the bronchial tube is sclerosis. So if we already see the connective tissue, so sclerosis, unfortunately, we can't give, actually we can obviously give a pill, but this pill, unfortunately, do not work. Already do not work. Because connective tissue we can't treat by medicine. So four main components: mucus, a lot of mucus, hyperplasia of the mucous layer, spasm, and the fourth one, and actually the last one that we can't treat, is sclerosis. So if we have sclerosis, the narrow lumen is permanent. So for sure. So here you could see this mucus, inflammatory infiltration in the mucous layer, hyperplasia of the mucous layer, as you see, hyperemia with dilated vessels. So all features of inflammation. Specific features of inflammation in bronchial asthma is domination of eosinophils. So neutrophils structure, but utterly pink cytoplasm or utterly eosinophilic cytoplasm. Next specific feature that you can use in your MCQ as a cornerstone is presence in the sputum, so-called Charcot-Leyden crystals. Charcot-Leyden crystals is in the sputum. Also you can use. Next disease is bronchiectasis. So what happens with bronchi in this disease? So normally bronchi are tubules. So you know, I hope. And due to some inflammation, exactly chronic inflammation, there is a damage of bronchial wall. This damage leads to dilatation of the lumen. So bronchial asthma we have oppositely narrowing. Here we have dilatation of the lumen. So lumen becomes wider due to the chronic purulent inflammation. Let's see. So you see, so there is a tendency towards abscess formation inside the bronchus. So abscess, so this is yellowish, greenish, cheesy fluid. In other words, this is like a pus. So grossly, you see the huge cavities with, again, could be horizontal level. Microscopically, you could see a lot of neutrophils as like a main feature of purulent inflammation. Here, you could see the connective tissue adhesion between the lobes. Here you see, so this is scarring, and it's difficult for lung to expand because of this connective tissue between lobes, but logically this connective tissue could appear in whole pleural cavity, and that's why leads to the obliteration of the pleural cavity and make worse the course of chronic respiratory insufficiency. One more point about the bronchiectasis. So classically, your MCQs contain questions about problems with kidney. So patient suffers for a long period of time with bronchiectatic disease, and right now they have a uremia. What is the cause of the uremia? So classically, we are talking about secondary amyloidosis of the kidney that leads to the chronic renal insufficiency. So from this seminar, you have two diseases that lead to the secondary amyloidosis of the kidney. So rheumatoid arthritis and also bronchiectatic disease. Okay, move on. Restrictive pulmonary diseases. So you see the four groups, and let's discuss some of them. So fibrosing diseases. So first of all of diseases are chronic. Usually they are autoimmune or related with some problems with immune system. And finally, all of them lead to the pneumofibrosis. So patient can't breathe, so chronic pulmonary insufficiency. Move on. Examples. Classical example is idiopathic pulmonary fibrosis. What do we have here? We have the inflammation exactly in the septa of the alveoli. So please look here. This is alveoli, and this is wall of the alveoli. You see how thick is it? Inflammatory mononuclear infiltration is present. A lot of connective tissue. So obviously this part of lung does not work, not like properly, mostly at all. So patient can't breathe. Chronic respiratory insufficiency. Interstitial pneumonia is also type of fibrosing diseases of the lung. So again, remember beginning of our lecture. So we said bronchopneumonia, we have lobar pneumonia, and the main focus of the inflammation localizes in the lumen of the alveoli. Here we have opposite situation. So inflammation localizes in the wall of the alveoli. That's why it leads to the pulmonary fibrosis and then chronic respiratory insufficiency more quickly. Next important point, term honeycomb lung classically relates to the idiopathic pulmonary fibrosis. Classically, you see the small cavities, a lot of cavities, so these cavities are like honeycomb. Also, in some literature, you could find this term with relation to bronchiectasis. So please do not mislead this one with, idiopathic pulmonary fibrosis and bronchiectasis. What's the main difference? Difference you need to find in the condition of your MCQ. If there is a cough in the morning, purulent sputum in the morning, classically, some temperature, high temperature, increased temperature, and some pus, so a lot of features of purulent inflammation in the body. So it should be bronchiectasis. If there is no features of active purulent inflammation and cavities are small or mostly are small, even tiny, so this is idiopathic pulmonary fibrosis. Move on. Pneumoconiosis. There are three main diseases that you need to memorize. Classical anthracosis, silicosis, and asbestosis. So, anthracosis has a dark color, dark sputum due to the presence of macrophages that accumulated actually coal. Yes, coal dust. And that's it. So this is anthracosis. Next one is silicosis. Also here lungs could be dark. So be carefully. So the main difference between anthracosis and silicosis is presence of so-called silicotic nodules. You see, collagenous-silicotic nodules. So this concentric, pinkish, fibrin-like structure are these silicotic nodules. So also there is a tendency towards cavern formation. So these features are specific tips for especially silicosis. So please pay attention, read carefully your MCQ condition. And last one is asbestosis. So here we have also specific feature, presence of so-called asbestos body. Here you see it in high magnification. So what is asbestos bodies? So they appear as you see, golden brown, fusiform or beaded rods with a translucent center and consist of asbestos fibers coated with an iron-containing material. So this is asbestos bodies. Next one, granulomatous diseases. So we have sarcoidosis. I remind you that sarcoidosis is a type or example of chronic productive granulomatous, non-specific, non-infectious inflammation. We have a granulomas formation with multinucleated giant cells. Classically, sarcoidosis affects lung, lymph nodes, and also there is a common case when sarcoidosis you could find in the skin. Cause is unknown. Also, sarcoidosis is considered as an autoimmune problem. Also, sarcoidosis is considered as an example of force type, so dilated type of hypersensitivity reaction. Next example is hypersensitivity pneumonitis. So this term describes a spectrum of immunologically mediated, predominantly, as you see, interstitial, so again in the wall of the alveoli, lung disorder caused by intense, often prolonged exposure to inhaled organic dust and related occupational agents, antigens. So it's really important to recognize these diseases earlier in their course, because progression to serious chronic fibrotic lung disease can be prevented by removal of the environmental agent. So here we have a cause, and if we eliminate this cause, we save actually life of our patient, because there is no treatment of idiopathic, for example, fibrosing alveolitis or interstitial pneumonia. There is no treatment, only like to endeavor probably to decrease the speed of the process development. It's really, really pity. So we can offer to our patient only transplantation of lungs. That's it. So hypersensitivity pneumonitis has several main examples or names. So for example, like farmer's lung. So this specific lung results from exposure to dust generated from, for example, harvested humid, warm hay that permits the rapid proliferation of the spores of actinomycetes. Next example is pigeon breeder's lung or bird disease. Also, there is a so-called humidifier or air conditioner lung that is caused by bacteria in heated water reservoirs. So again, so we have severe problem with immune system. So classically we have accumulation of T lymphocytes, and there is relation with third, so immune complexes, type of hypersensitivity. And finally will be the fourth type, hypersensitivity, with formation of granulomas. So histological changes in in subacute and chronic forms are characteristically centered on bronchioles. So they include, first of all, interstitial pneumonitis and non-caseous granulomas, and also leads to the pneumofibrosis. Pulmonary vascular diseases, so pulmonary embolism, hemorrhage and infarction, pulmonary hypertension, and diffuse pulmonary hemorrhage syndrome. So you see here thromboembolism of the pulmonary truncus that leads to the sudden death because of the pulmocoronary reflex. So pulmocoronary reflex contains, firstly, spasm of the bronchi, secondly, spasm of the coronary arteries, and thirdly, spasm of the arteries of the small circle. So that's why we have at one time, at one moment, acute respiratory insufficiency and acute heart failure, and patient die. This is a gross spacement, I hope familiar for you, gross spacement of the infarction of the lung. So classically red color, triangular or wedge shape, more dense consistency, classically is caused by thromboembolism of pulmonary artery. I remind you again, colleagues, we have the main source for thromboembolism of the pulmonary artery, and this source is vein of the low extremities, pelvic vein, or even right part of the heart. So any level of veins, like veins part of the circle, any level. So rheumatic fever, myocardial infarction of the left ventricle, SLE with Liebman-Sachs endocarditis can't lead to infarction in the lung. There is only one possibility, if there is a defect between the left ventricle and right ventricle. That's it. In all other cases, if we have source of thrombus in the arterial part, we have infarction in the organs. If we have source in the veins, so we have infarctions in the lung. That's it. So this is the main rule. Please pay attention when you read your MCQ. Lung tumors. Huge number of categories, a lot of different malignant processes, but we have one, unfortunately, main tendency. So unfortunately, lung cancer is one of the most popular killer from all malignant carcinomas. Unfortunately, there is no effective treatment, and as you see, there is really low survival rate in this disease. So carcinomas on the lung. So repeat again, yes. So patient smokes, patient then has a chronic bronchitis with metaplasia, then dysplasia, and then carcinoma in situ firstly, and then invasive carcinoma. On this slide we see so-called centrid, so near the main bronchus, carcinomas. So this is center located carcinomas, and this is squamous cell carcinoma with keratinization. See here, keratinization, formation of so-called keratin pearls. This pinkish concentric structure. So keratin pearls means keratinization. That's why this is invasive squamous cell carcinoma. Again, you see keratin pearls inside, so some mitotic figures that also show a level of malignancy. So if you remember, also mitotic figure is so as higher mitotic rate as more malignant this tumor. So adenocarcinomas of the lung. So here you see adenocarcinoma, so presence of glands. So atypical hyperplasia. So remember, so hyperplasia becomes metaplasia, yes, and when hyperplasia becomes directly dysplasia, so-called atypical hyperplasia. So it could lead to the adenocarcinoma. So this gross basement shows us so-called distal or peripheral cancer of the lung. Look here, please. Adenocarcinoma is the one cell type of primary lung tumor that occurs more often in non-smokers or smokers who have quit. Next one, bronchoalveolar carcinoma. So another example or subtype of malignant tumors, and this tumor is one of the, I can say, like one of the best tumor in possible, the best in prognosis for life. Neuroendocrine tumors could be divided into the small cell carcinoma. You see like small dark blue cells with high mitotic rates as usually, and so-called large cells we see on the next slide, large cell carcinomas. Here is an odd cell carcinoma, which is spreading along the bronchi. Prognosis is unfortunately also poor. So, and large cell carcinoma, here you see the growth. So you see the large tumor cells significantly. So this is lymphocyte, for example, so inflammatory infiltration lymphocyte. So you can compare the size of this cell and malignant tumor cell. So it is bigger in 40 times, so significantly bigger. So features of neuroendocrine carcinoma are, firstly, they could produce some hormones, and also they could be treated. We have some protocols and some specific drugs for neuroendocrine carcinomas. Obviously, it depends on a lot of circumstances, but theoretically, we have this treatment. Next classical example, example of malignant tumor is mesothelioma. This is not directly direct tumor from lung tissue. This is tumor of the pleura. And the classical risk factor is asbestos exposure. So that asbestosis as pneumoconiosis could lead to the malignant tumor of the pleura, mesothelioma. And the last important point about malignant tumors. So these small multiple small foci in the lung are metastatic carcinoma. So these are metastases, and metastases to lungs are more common than primary lung neoplasm. That's why it's really important to take the biopsy from this focus or eliminate some part of lung and see microscopically what is this. Is this primary tumor or this is a metastase? And to sum up, to revise that information that you have heard during this lecture, I give you this clinical case. I present to you this clinical case and please you to give an answer in our Google form as sign of your presence during the lecture. So, thank you for your attention. I hope this lecture was interesting, and what is more important, this lecture was useful for you and for your awareness about the lungs pathology, bronchial pathology, and related with these pathology diseases. So, stay healthy, take care of yourself, of your neighbors, of your relatives, and have a nice day. See you next time.